spinal cord, multiple sclerosis. It is a focal or diffuse spinal cord signal abnormality on T2-weighted MRI, resembling those seen in the brain and are detected in up to 90% of the cases. The clinical diagnosis of MS are frequently asymptomatic. Focal MS, it could be cervical, mostly in the cervical region, less commonly in thoracic and upper lumbar region. The sagittal view, they are classically show a cigar shape, rarely exceeding the 2 vertebral segment index. In cross section, it's located in lateral, posterior lateral of the cord with white matter column, do not sparing the central gray matter. Less than 50% of the cross section will involve. The lesion rarely affected exclusively anterior column and of the central cord, seldom occupy more than half of the sectional area of the cord. Enhancement of the lesion is less frequently in the than in the brain MS. Its brain enhancement lesion is about 4 to 10 times more common than the spinal cord. Less commonly will be diffusely involved in the spinal cord. This will be one of the differential diagnoses called myelitis or neuromyelitis optica. In long-standing cases, there will be atrophy in the spinal cord. 1/3 of the patient there will be they will have spinal symptom, and 1/3 of the patient isolated spinal multiple MS without any finding of the brain. This will be representing about 30% of the cases of the spinal MS. However, the pathological study have shown that the 95% of the multiple MS patients have a spinal cord lesion where they have a spinal symptom or not. This is the T2 and proton density sagittal MRI show the focal small, less than 2 vertebral lesion in the posterior, high signal lesion in the posterior lateral aspect of the cord. It is representing a classical type of the MS lesion. Again, this is a 3 different patients, which is this focal lesions, which is focal type of the lesion, and less frequently the diffuse type of the spinal cord involvement, which is a differential diagnosis of the transverse myelitis and neuromyelitis optica. And in chronic case, there will be atrophy of the spinal cord. And in cross section, the MS lesion usually appear as a focal lesion, as a round focal lesion, or it could be a triangular shape in the posterolateral of the section. So we can exclude the spinal MS lesion if it's anteriorly isolated. Unfortunately, no, we cannot exclude the MS lesion if it is anteriorly isolated anterior lesion. This is the classical one in the posterior and lateral of the cord, while the lesion you see it exclusively in the anterior located in the cross section. This is uncommon, this presentation, but you cannot exclude the multiple sclerosis in this case. Enhancement of the cervical MS could be either ring enhancement or hyperintense high signal uptake of the contrast, or fairly less intense enhancement. Most of the lesions are in this type, or rarely we see the hyper enhancement or ring enhancement in the cervical MS. This is the summary of the we say in the previous. Of the lesion are supratentorial or infratentorial. The morphology of the sharply marginated oval or round, bilateral, slightly asymmetrical, signal intensity low or intermediate in T1, hyperintense in T2, enhancement, nodular homogeneous or ring enhancement, optic neuritis involvement, spinal cord lesion, as we say, it is mostly in the cervical, short segment is involved and located in the posterior lateral of the lesion. MS variant, we have many variants of the MS. The first, Marfan disease, which is a malignant type of the MS. It's a rare acute type of multiple sclerosis, various variant, and occur predominantly in the adult. It is rapidly progressive and occur with frequent severe relapsing, leading to the death and severe disability within the week or month after the onset of the clinical sign, mainly from the brainstem involvement and mass effect of the with herniation. Marburg disease is preceded by the febrile illness. Usually, this disease also may be considered as a fulminating type of Adam if it has a monophasic course. Pathologically, Marburg disease has more destructive nature from the multiple sclerosis and the Adam, and are characterized by the massive macrophage infiltration. Despite of the destructive nature of these lesions, the area of remyelination are often observed in the lesion. On MR, MR show multiple focal T2 lesion with various sides may coalesce to form the large white matter plug disseminated throughout the hemispheric white matter and the brainstem. Perilesional edema and enhancement are commonly seen. This is Marburg disease. In the early stage, there will be multiple subcortical white matter T2 lesions, and by the time will be coalesce and become more prominent and appear as a large area of high signal, while in the subsequent the lesion decreases the size and will be highly response with high treatment of the high dose. There will be resolving of the lesion. The second type is shoulder disease. It's also a rare type with acute disorder that can be defined as a specific clinical عفوا الأستاذ صوتي اتصل.
زين مفهوم زين صوتك كمل shoulder disease.
Okay, it's a common affect shoulder disease. Commonly affect the children and the young adults. The clinical spectrum of the shoulder disease includes psychiatric predominancy, acute intracranial hypertension, intermittent exacerbation, and progressive duration. MRI usually is the large ring enhancement lesion involving both hemispheres, sometimes symmetrically preferential into the parieto-occipital region, minimal mass effect with restricted diffusivity. On pathological, there will be well-demarcated demyelination and reactive gliosis with the relative sparing of the axon. Microcystic change will happen, and even the frank affiliation may be seen. The clinical and imaging finding usually show a dramatic response to the steroid. This is a case of shoulder disease, large demyelinated lesion involving both brain hemisphere with an open ring enhancement pattern. They preserve it is classical enhancement of the ring enhancement in the MS lesion. Balu concentration is sclerosis. This is also a rare condition, aggressive variant of MS that lead to the death in week to months of the onset. Large demyelinated lesion showing the peculiar pattern alternating layer of the preserving and destroying myelin. Better identified in G2, typically thick concentric hyperintense band corresponding to the demyelination classes. Alternative thin iso-intense band corresponding to the normal myelinating white matter. On T1 weighted image, iso-intense represent myelinated layer, while the hypo-intense represent demyelinated concentric ring. The band, which may be eventually disappear over the time, can appear as a multiple concentric layer, as an onion skin lesion, or a mosaic or a floral configuration. The center of the lesion usually show no myelination because the massive demyelination or stored center. Contrast enhancement on diffusivity, frequently the outer ring of the lesion will be enhanced. It can isolated or multiple or mixed with typical MS lesion, predominantly in the cerebral hemisphere. This is the case of the Balu concentration. If you see alternating hypo and hyper intense layer with central, two different patients show large focal white matter lesion with laminated pattern of the alternating bantu of demyelination and relatively normal white matter, reflecting either sparing or remyelinating lesion. This alternative one, this is representing either demyelination, remyelinating part or normal myelination. This is another case. This is alternative concentric band with peripheral contrast enhancement. This is the peripheral contrast enhancement, and with outer layer low hypointense layer in ADC map representing restrictive diffusion. A pseudotumor lesion on MRI. This pseudotumor lesion usually presented as a large single or multiple focal lesion located in the brain hemisphere, resembling the brain tumor because of the hypercellular nature of the lesion, relatively minor mass effect, and pathogenic edema. Incomplete enhancement on T1 gadolinium enhancement, open border facing to the cortical or subcortical white matter. The differential diagnosis is between the malignant glioma and pseudotumor demyelination brain lesion may be impossible because slowly they are conventional. It is impossible in conventional MRI, but proton density with MR spectroscopy it may be useful. This is the three different patients. This is the multiple sclerosis tumor. This is intracerebral tumor, and this is metastasis. Both of them had this ring enhancement, while only the multiple sclerotic lesion or pseudotumor had an open ring enhancement facing the cortex and subcortical white matter. This is metastasis, however, it is in subcortical or gray white matter junction, but it is not. It is a complete ring enhancement. This is the way for differentiation in the pseudotumor from the metastasis and the glioma. Neuromyelitis optica, it's another entity which is a severe demyelinated disease caused by the auto antibody to the aquarin 4 water channel. It is an antibody against the astrocyte water channel in the CNS, clearly identified neuromyelitis optica as a disease of separated from the multiple sclerosis. A classical presentation of neuromyelitis optica. It has optic neuritis, longitudinal extensive myelitis. It is in the cervical. More than 4 to 7 vertebral segments are involved with the fully transverse diameter of the cord. It looks like transverse myelitis with a positive AQP4 antibody in the serum. Female to male ratio is more 9 to 1. Median age is of course 20 crores, about 10 years later in the multiple sclerosis. Optic neuritis involvement is typically manifested as severe unilateral or bilateral optic neuritis. Complete acute spinal cord syndrome is a classical clinical manifestation of the spinal cord region. Intractable nausea, hiccup, vomiting, and involvement of the dorsal area of the medulla oblongata. Patient with diencephalic involvement may have narcolepsy, anorexia, inappropriate diuresis, and hypothermia and hyposomnia. In brainstem involvement, oculomotor dysfunction will be present. In about 85% of the patients have relapsing course, like multiple sclerosis, with severe acute exacerbation and poor recovery would lead to the increasing neurological impairment and high risk of the respiratory failure and death due to the cervical myelitis. On MRI, there's 3 or more contiguous vertebral segment, and occasionally the entire spinal cord is involved. It means long element transverse myelitis. The lesion is located centrally, preferentially central gray matter involvement affect much of the cross section of the axial image. Long element transverse myelitis lesion are more specific radiological findings supported the neuromyelitis optica in diagnosing the adult patient. So short transverse myelitis defined by the lesion to the less than the 3 vertebral segment are involved. Acute and subacute phase, the lesion are time effective and show contrast uptake. The presence of the very hyperintense spotty lesion on T2 image and bright spot, a specific feature for the differentiating NMO from the multiple sclerosis. The spinal cord region can progress to atrophy and necrosis and may lead to the things like the cavity on T1. Negative brain MRI at the disease onset was considered in a major supportive criteria for the diagnosis of NMO. It's about 24 to 85% of brain involvement. Diagnostic criteria of optic neuritis, transverse myelitis, and evidence of the sarcoid, no evidence of the sarcoid or vascular or lesion. This is case of the 24-year-old woman presented with acute bilateral visual loss, coronal T2 and the axial contrast show demonstrate the hyperintensity enhancement lesion involving the optic chiasma. Usually the involvement of the optic nerve is long segment, and posterior one will extend to the intracranial part of the course of the optic nerve. And in chronic case, there will be atrophy of the cord of the nerve. This is again the cervical type. In first patient, there will be a longitudinal extensive myelitis involving the cervical cord, which extend to the area of theta. The lesion show intense peripheral enhancement. This is the long involvement of the long cervical with after enhancement show the peripheral enhancement. While in the second stage, the myelitis extend to the brainstem with hypointensity 2 pseudo thinning. If you see the hypointensity in the middle of the curve, it's represented as the thinning of the lesion. With another type of bright spot appearance, and those are classical for differentiation from the multiple sclerosis. Also, the multiple could be NMO could differentiate the type of the. It is the T2 flare with MRI show the hyperintense lesion involving the corpus callosum and the hypothalamic region and the dorsal portion of the bones, also involving the dorsal portion of the bone, and also corticospinal tract in the double inversion recovery. Corticospinal tract will be involved. This is the logical feature difference between neuromyelitis optica and the multiple sclerosis. Usually in the brain, multiple sclerosis is a small size lesion. It's variable in size. Dissemination in space in the multiple sclerosis is present, while in the dissemination in the space is not present in the neuromyelitis optica. Corpus callosum, usually focal or inferior margin corpus callosum, diffusely wholly which are involved. Periventricular lesion are seen in the multiple sclerosis, while in the periventricular following the ependymal line in the neuromyelitis optica. Hypothalamus, thalamus, and hypothalamus uncommon, while common in the other type. Brainstem dorsal, but foul surface intraaxial trigeminus, while in the neuromyelitis around the fourth ventricle. On an optic nerve, usually unilateral or short segment are involved in multiple sclerosis. In the neuromyelitis, more commonly bilateral and long segment extension. Spinal cord, it's less than 2 segments in the MS, while in the NMO, it's more than 3 segments, usually marginal in the central, and less than half of the spinal cord in the ABS involved, while entire diameter will be involved in the NMO. Nodular, and the enhancement will be nodular or homogeneous variable patchy enhancement in the NMO. A differential diagnosis of the multiple sclerosis. We have long list of the differential diagnosis. We can categorize as inflammatory, vascular, infective, metabolic, and toxin, and neoplastic. The first of all, inflammatory, it involves ADAM, Neurosarcoid, Neurovascular, Clipper syndrome, and Pact syndrome. Primary or secondary vasculitis, SLE, and ependymitis granularis. ADAM is an inflammatory demyelination disease of the CNS after the viral infection or vaccination. Has a history of the infection. In about 75% of the patient, there is a clear infection event or vaccine, 1 to 4 weeks prior to the disease. Typically monophasic in 90% of the cases. Multiphasic illness in 10%. In this case, ADAM behave like multiple sclerosis and cannot be differentiated from it. Mostly seen in the young children, 5 to 8 years of the age. Incidence about 0.3 to 0.6 per 100,000 per year. In 50% of the ADAM patient with monoclonal IgG test positive and supportive diagnosis. This is antibody reactive against the myelin oligodendrocyte glycoprotein. The clinical history typical for the Adam. For Adam, usually the brain is also involved in 30% of the cases have the spinal cord involvement. Clinical course of Adam is typically rapidly progressive within the 2 to 5 days. Unlike lesion of multiple sclerosis, Adam lesions are often patchy and poorly marginated. Lesion usually large, with, from few millimeters to several centimeters. The large lesion mass effect will be mild in the large lesion or absent. Avoid Dawson figures are much less frequent in the compared to the MS. They usually asymmetrical involvement of the subcortical and central white matter and cortical gray white matter junction of the cerebral hemisphere, cerebellum and brainstem and spinal cord. Lesions confined to the periventricular white matter and corpus callosum are less common than in the multiple sclerosis. The gray white matter of the thalamus and the basal ganglia often affected, particularly in children. Sometimes the asymmetrical pattern. The cortical gray matter involved in 30%. Gadolinium enhancement is uncommon, about 40 to 30% of the cases. Complete or incomplete enhancement are nodular as the type of the, or spotty enhancement type of enhancement. This is teenage with a typical history, 3 weeks after the respiratory infection, sudden onset of the neurological symptom, dysarthria, dysphagia, and tetraplegia, eye movement disturbance, and impairment of the consciousness. This is the long segment T2 high signal with enlargement, swelling of the cord, with no enhancement in the after gadolinium enhancement is typical for the transverse myelin. The clinical history is typical, and usually the brain is involved in 30% of the cases. The image finding case are also typical. There will be swelling of the cord, involvement of the like the transverse myelitis, no enhancement of the cases. When examine this case in the brain, there will be multiple brain involvement with multiple high signal spot in the subcortical white matter. But what is differentiating in this case from brain involvement from the multiple sclerosis is the involvement of the basal ganglia and the involvement of the pons, diffusely involvement of the pons, which is not classical, not seen in the multiple sclerosis. This is another case of Adam involvement, multiple patchy large area of T2 hyperintense signal in the centrum cerebrovascular and the cord involvement, which is usually involvement with recovery after the with no enhancement in the after contrast. Another case, it is involved cervical involvement, high signal with multiple lesion in the basal ganglia and subcortical white matter, also involvement of the diffusely of involvement of the pons. It is in follow-up in these cases after the treatment, there will be a complete recovery, which is unlike for the multiple sclerosis. Again, this is the case of 12-year-old boy. This is observed the symmetrical involvement of the subcortical hemisphere white matter with both thalamus and diffusely the pons. Subcortical lesion with thalamus are involved and the diffuse involvement of the pons, which is classical for the MS lesion. In the cervical, the clinical evidence show the extensive spinal cord hyperintense involved in the male thoracic region. It's from the cervix and the thoracic region with complete recovery after the few weeks later. Again, this is how the contrast help to differentiate between the MS and Adam. In Adam, there will be no enhancement, multiple patchy area of subcortical lesion. In post-contrast, there is no enhancement, while in multiple sclerosis, there is few lesion, enhancing lesion, which is could be differentiated type, one of the way to differentiate from the Adam. How clinically we differentiate Adam than multiple sclerosis? Usually, the Adam is monophasic, while MS is multiphasic. Viral triggering is present in the ADAM, while not in the multiple sclerosis. CSF side is present, oligoclonal band in the multiple sclerosis, spinal cord transverse myelitis was short segment in the multiple sclerosis. Usually, in the follow-up, there will be full recovery in the ADAM, while the new lesion may be seen in the multiple sclerosis. On MRI, usually the lesion in the are fuzzy, or those things that are well demarcated in the multiple sclerosis. Gray matter involvement in the thalamus is common, while in juxtacortical in the multiple sclerosis are juxtacortical was unusual to be the gray matter is involved. Gadolinium patchy or absent enhancement, while in the multiple sclerosis is focal. Spinal cord lesion is long and swollen, while in the multiple and small, and also the recovery resolution will be seen in the follow-up, while the new lesion will be seen in the multiple sclerosis. Acute ADAM variant have two type of the ADAM variant, which is Baker-Staff encephalitis, which is a rare immune-mediated condition believed to be one of the number of the conditions sharing similar immunological mechanism and collectively termed anti-CQIB IgG antibody syndrome. Clinically, following varicella zoster, usually it's followed by varicella zoster or cytomegalovirus infection, it typically present acutely with the cerebellar ataxia external ophthalmoplegia. They may also demonstrate drowsiness, hemisensory disturbance, as well as the brisk reflex and extensive frontal response. On MRI, the brainstem and basal ganglia and the characteristic MRI are usually involved. The characteristic high T2 signal with little any enhancement demonstrate some minor restrictive diffusion. Treatment usually self-limiting with good prognosis. This is these are the brain showed extensive brain stem involvement of the cases and was fully recovery in the follow-up after its case a month later. This is the Baker-Staff ADAM. And another type, acute hemorrhagic leukoencephalitis. It's also known acute hemorrhagic leukoencephalitis, and it's very rare from the demyelinated disease. It is sporadic and may be considered as a most severe form of ADAM. Acute rapid progressive formatting inflammation of the white matter, post-infection, usually viral or bacterial. Clinical, the patient presents with the fever, neck stiffness, fatigue, headache, and nausea, even in the coma. History in the upper respiratory infection to precede neurological symptom at the interval 2 to 12 days and may present in 50% of the cases. MRI is the gold standard and maybe depict aforementioned morphological changes. It could be large time effective lesion involving the white matter and sparing the cortex associated with punctate hemorrhage, which is the sign for differentiation and extensive mass effect surrounding edema, possible involvement of the basal ganglia and thalamus. Detection of the microhemorrhage of the grade and selectively weighted image is an important finding and allow the differentiation from the ADAM. This is the case of acute hemorrhagic leukodystrophy in the 10 years old. Image show large white matter lesions involving both brain hemisphere, while hemisphere associated with multiple microbleed. There's evidence because of the increase in transcranial pressure and severe brain edema show the craniotomy to be for decompensation. Craniotomy is seen in these cases. Has a bad prognosis, a poor prognosis, with majority affected individuals succeeding to the disease. Another entity is neurosarcoid. It's relatively common among the patient with systemic sarcoids and has a building variety of the manifestation, often making the diagnosis difficult. The patient is usually 30 to 14 years of age, female predilection. CNS involvement is about 20%, and systemic sarcoid, although only 10% are symptomatic. Radiological feature usually scalp involvement, pachy involvement, leptomeningeal involvement seen in up to 40% of the cases, pituitary and hypothalamic and cranial nerve and parenchymal involvement, which is the most common type. On MRI, usually in general, the standard region in Q2 iso or hypointense adjacent to the gray matter, variable in Q2 variable, most commonly hyperintense. Some lesion can be iso or hypointense. On gadolinium homogeneous enhancement always seen. CT has a role in non-contrast scanning lesion. They pachymeningeal, leptomeningeal, parenchymal and appear at hyperintense, hyperdense area. As often the only finding is hydrocephalus due to occult leptomeningeal infection. This is the lesion will demonstrate multiple wide matter, deep wide matter lesion, also seen in the this case homogeneous enhancement regarded as a neurosarcoid. Bahajat disease, it is the systemic vasculitis with recurrent oral or genital ulcer, intraocular inflammation, neurological involvement less frequent, and if it is neurological component has a bad prognosis. Involvement of CNS central nervous system usually presented after the systemic manifestation, but about 3% will maybe CNS manifestation which precede the general common sign of the Bahajat disease. Neurological manifestation include the focal meningoencephalitis, cerebrovascular syndrome, seizure, cranial neuropathy, myelopathy, and encephalopathy. The disease may follow the relapse and remission course. Mesodencephalic junction and cerebral peduncle, pons, midbrain, and spinal cord are site of predilection. Bisanguinal internal capsule and optic nerve may be involved. The hemispheric region, there is no predilection or periventricular region compared to the multiple sclerosis. Brainstem lesion without any cerebral white matter change may be seen in Bahajat disease, which is quite unusual in the multiple sclerosis. The lesions of the neurobahajat disease typically involve in order of the prevalence. The brain stem most common and typical for the pons. Basal ganglia is bilateral and 1/3 of the cases. Thalamus and subcortical white matter less common. Spinal cord is less common than the multiple sclerosis. Demonstrate the following characteristics: usually hypointense in T1, usually hypertense intense in Q2, associated with the vasogenic edema in acute phase, and the lesion caused the mass effect. Moderate patchy enhancement with gadolinium, restricted, slightly hyperintense or restricted in the diffusion. Drop in the N-star state with elevation of the lipid and choline creatinine ratio. This is axial T1 image. Patient of the Bahajat disease demonstrated the severe ill-defined hyperintense lesions around the lateral ventricle, and this is also the patient with disease demonstrated the pontine lesion, hyperintense lesion in the pontine, with the predilection of the preferable site for the Bahajat disease. Clipper syndrome, it is a chronic lymphocytic inflammation with a pontine perivascular enhancement progressive to the steroid. Responding to the steroid is an uncommon and the only recent described disorder characterized by the infiltration of the brain by the inflammatory cell. It has a predilection for the pons with fairly characteristic curvilinear region of enhancement best seen in MRI, respond to the immune suppression with the corticosteroid. MRI of the clipper is multiple punctate, patchy, and linear region of contrast enhancement relatively confined to the pons, caudate and dorsal of the pons, cerebellum, peduncle, and cerebral hemisphere may be involved. Little edema is present, positive mass effect, no vascular angiographic change. CV revealed prominent vein in the punctate region of the. This is case axial
دكتور بعد عندك هواي كيس بعد عندك هواي؟
نعم دكتور، هو كلش طويل الديفرنشال دايجنوستس.
لا هسه بعد ايش قد عندك؟ ايش كم سلايد؟
هسه
واحنا عندنا اجتماع بابا.
اي نعم دكتور، بس يعني هو اكثر من 160 سلايد. يعني كل
هسه وين وصلت؟
بال90 هذا.
لا بابا، انهي هسه، انهي